from the EMRAP studios in beautiful Los Angeles, California, it's Invictus Live! Your faculty tonight are Britt Guest, Mizaho Morrison, Sean North, and Stuart Swadron. And here he is, your host, Matthew Delaney.
Welcome to Invictus Live. I'm Matthew Delaney. I'm going to be our host for tonight. Before we get started, let's bring out the CEO of EMRAP, Mizaho Morrison, a woman who needs no introduction, yet here she is. Mies, welcome.
So EMRAP has always been a leader in education, from the ground up, throughout residency as foundational learning, all the way through your career. However, we've noticed with the trending board scores going down, we needed to be part of the solution. So internally, EMRAP developed a residency task force with program directors and lots of our internal faculty to help fix some of this problem, starting with study guides, which you'll hear all about with Dr. Britt Guest in a moment.
And one of the things that came out when we got this task force together was we needed to reboot the way we study for boards. Honestly, the way we did it was dry, so we've totally revamped it. We have Invictus reviews for the written boards, Invictus Encore for the oral boards of the new certifying exam. That's kind of what we're going to go through tonight. Reviews
has over 70 hours of lecture videos with emphasis throughout, so you don't miss any of the nuanced things that ABEM loves to test you on.
Yeah, and with Invictus, there's other stuff. So there's a podcast hosted by Andy Little, and what we do on that show, and it's updated regularly, is really try to dive into the minds of the people who will write these questions on the board, so you have that extra thing you need when you sit down to take the test.
Each lecture also comes with study guides and cram sheets, so you can quickly run through all the last-minute things you have to remember before you sit down for the boards.
And it's all live online right now, but coming very soon, we've got a question bank, or the Invictus Q Bank, that I think really will be kind of the chef's kiss that ties it all together and gets you ready for the boards.
So we are super pumped for tonight. A special thanks to our audience. We have residents from USC and UCLA here, so thank you so much for being part of it. And thank you to our home audience who is chiming in. And we have actually 2 trivia questions. Delaney, you want to tell them what that is all about?
So if you're listening online at home, you can go into the comment section on YouTube, and when we pop the trivia questions up, the first 2 people to get the answers right will get a subscription to Invictus and then a subscription to Encore.
All right, and with that, I know you have an awesome game show. I can't wait to dive in, but I think we first go to Britt Guest to talk about our new residency study guides.
Hey guys. We have some new study guides that I want to tell you about coming out on the EMRAP platform. Now, I remember being an intern and having everyone tell me, read more, study more, make a study plan, and feeling like my head would just explode because I had no idea where to start. That's what we really did with creating these study guides. And EMRAP is a great resource. We have so many programs on our platform, but I will admit that especially being a junior learner, first accessing EMRAP can seem incredibly overwhelming. And even with this great resource, where do you begin? So we created these study guides, and you might be saying, well, I'm in a 3-year program or I'm in a 4-year program. Is there a study guide that's going to fit all of these different styles? There is talk about programs all going to 4 years. We're not there yet. There's still a lot of 3-year programs that we want to support. So we made study guides for everyone. We've got our 3-year study guide, our 4-year study guide, and I want to point out that Dr. Whit Johnson created our very first 3-year study guide. This will be on our platform through June 2026. Once you go through that, if you're still using that, that's completely fine. Once you start your new academic year in July, though, you'll move to the 3 or 4-year program depending on where you are. Now, I want to talk about how to find these study guides on our website. You go to our platform, you go to our main page, and you go to our textbook compendium. That's where these live. You can either search for study guides or you can hit chapters, which is my preferred way to get there. You go to chapters again, it'll take you straight to all these study guides. The sections here are all the sections within compendium. Study guides is one of those sections. Now, let's say I'm in a 4-year program and I'm a PGY1. This is where you're going to start. This is week 1, July, beginning of your whole residency journey. We have a structured longitudinal curriculum for you. It will take you through everything you need to know in residency from year 1 to 3 or 4. And it'll tell you everything you need to do. These are based off of the ABEM model for clinical practice. So everything you need to know for the boards, and of course for being a great clinical, a great practitioner in the future. Now I want to just take an example of a week. This is week 14 and it falls in trauma. Now we know that some people are more visual learners. Some people really like audio. Some people love to sit down with a book chapter, and we have it all here for you. So we've made a multimodal learning plan where we have Compendium book chapters, EMRAP segments, fundamental videos, procedure videos, and images pulled from our huge media library. So you get all different styles of learning, and each week is curated, so it shouldn't really be more than 5 hours to get through the content of each week. We know you're crazy busy, you're working night shifts, you're doing ICU off-surface rotations, your time is precious, so we want to optimize these weeks to really only take 5 hours and get all the content you need. On top of that, if you like a PDF, if you like to print these things out, we have a beautiful PDF for you, and they come with checkboxes. I don't know about you, but sometimes I just put a checkbox next to things so I can check them off because it makes me feel better. So if you like checkboxes, this is the way to do it. Print it off, check it off as you go, and make your way through the content. You're going to start with your PGY 1 year if that's where you're starting first in your intern journey, which is going to set the foundation, core clinical knowledge, everything we all need to know and start with. As you go through the years to PGY 3 or 4, you're going to get topics that are more critical care based and nuanced. And so from year 1 to year 4, we're going to be behind you the whole way, getting you through this whole journey of learning for residency and the boards. Remember, if you have a EMRA membership, EMRAP is free and those study guides are included. We are all here to support you and really excited to get these study guides out. So with that, I think there's a really cool board game, but there's a video that will show the weird interworkings of some of the EMRAP production team.
It's April, and that means it's the end of spring for the Northern Hemisphere. It also means that on the top half of the Earth, there's going to be a lot more drinking, debauchery, daredevilry, and bad decisions. Well, it's time not only to say thank you to all of this year's upcoming heroes of poor judgment, but every one of those heroes of the past. The unsung champions of inebriation, who really should have known better, but luckily for the emergency departments all over the planet, chose not to know better. To the guy setting off fireworks in the living room,
You put it in the wrong way!
we salute you. To the woman trying to plank on the stove by holding onto the oven door, cheers. Here's to you roof jumpers, you indoor cyclists, you nutcrackers. Here's to you mavericks of ill-conceived plans at 2 in the morning. You pioneers of teenage miscalculation and middle-age miscalculation. To all you heroes who make the emergency department so exciting, thank you. And to everyone who decided to start a bonfire with 5 gallons of petrol, thank you. To everyone over 200 pounds willing to try parkour for the first time, thank you. And to every naked person who slipped onto something rectum first, thank you. Thank you for stopping by.
Get ready for Rapid Fire Board Busters, a game show about the boards that's even more fun than the actual boards. Let's play Rapid Fire Board Busters.
You may call it a board game. It's not. This is Board Busters. So welcome. 2 goals here. One is to win. The second is to learn along the way. So we got some stars up here playing for Team Invictus. We have Phil and Brainerd playing for Team Encore, Sophia and Sammy. Thank you. Thank you. And we've got our expert panel, Dr. Sean Nort, Dr. Stuart Swadron. These are the guys who are going to help us understand why we can't always get the answers. So this is going to be fantastic. It's a fairly simple game. So we spin the wheel gets spun in the back, and you'll either get one of 2 things on the wheel. It'll either be a point value, or you'll get some surprises. Now, it's not a good surprise. If you get the surprise, you lose all of your points, and you don't get to answer, and it goes to the other team. And then at the end, we'll see who has the most points and who wins and who learns. So any questions before we get started? All right, the one thing I would ask is, even if you know the answer, if you'll wait for me to read the potential answers so that people playing at home can get it all. But let's roll right in. All right, hit the wheel. All right, big money, big money, big money. All right, 300-point question. All right, buzzers ready? You guys got the buzzers? All right, sweet. A 3-year-old child is brought to the ED after ingesting an unknown amount of his grandmother's medication. He's symptomatic with bradycardia, hypotension, and a blood glucose level of 45 mgs per deciliter, 2.5 millimoles per liter. His mother mentions grandma takes some kind of heart pill and a blood pressure pill. Which of the following ingestions is most likely responsible for the child's presentation? A, amlodipine, B, metoprolol, C, digoxin, D, clonidine. All right. Oh, all right.
Is that how? Okay. B, metoprolol.
B, metoprolol. All right, perfect. So that's 300 points for Team Invictus. And let's kind of talk through here. So I struggled with this question initially, but really it's just a matter of kind of whittling down what I think is probably not the right answer. So things that can cause bradycardia. Calcium channel blockers can, digoxin can, beta blockers can. That doesn't really get me there. What can cause hypotension? So that's gonna be calcium channel blockers or beta blockers, but the key I think for this is look for that sugar. So beta blocker is gonna cause hypoglycemia. Calcium channel blockers will cause hyperglycemia because it blocks insulin release. So I think that's a great classic board question that they love. And again, we kind of reason our way through these answers. So 300 points, let's hit the wheel. Ooh, 500 points. All right, this is a tougher question. I got faith in you guys. A new lab test is developed and tested on the general population to diagnose HIV. What change would be expected if this test was used on a population with a known prevalence of HIV of 80%? All right, so A, increased negative predictive value, B, increased positive predictive value, C, increased sensitivity, or D, increased specificity? Not a lot of fast buzzer action. You got a 25% chance of getting this one right. So
I think it's actually like closer to 10% chance.
all right. Phil, brave, I like it.
Increased positive predictive value.
We've got a ringer over there, Phil. Increased positive predictive value. Now the good news is we're not going to ask you to explain this, but Stuart, we're going to ask you to explain this.
I hope I can do this without. I hope I can do this without screwing. Can you put the question back up there for a second? Because you have to know this, right? I mean, there's going to be, if they're going to pick a question on evidence-based medicine, this is the one, right? You need to know the difference between these 4 entities. And I think for most of us, we think of the square and the true positives and the false negatives, and like, I'm going to get this confused. I'm going to screw this up. So I have my approach is I have a mantra, right? Which was that the sensitivity and the specificity of a test do not change. They do not change. This is talking about changing, okay? They do not depend on the incidence or the prevalence of the population. So those you can throw out. Right? It has nothing to do with that. Those don't change. And then if the rate of HIV goes sky high, obviously the predictive value of the test is going to be much, much better. So the increased positive predictive value goes up. So that's exactly right. And so just remember the mantra, which is the sensitivity and the specificity of a test do not change. And then you can get most of these right when you just go from that.
You make it so simple. I've heard you say that before, and I need to hear it several more times, but I think that's a great breakdown. And this is the kind of thing the boards will throw up there. So that's a fantastic question. All right, somebody hit that wheel. 100-point question. All right, a 28-year-old female with a history of asthma presents to the ED in severe respiratory distress. She's speaking in one-word sentences and uses her accessory muscles. Her heart rate is 135. Her respiratory rate is 34 breaths per minute. When you listen, the chest is notably, quote, silent, with minimal air movement bilaterally. Which of the following findings on an ABG would be most concerning in terms of this is impending respiratory failure? So A, a pH of 7.45, B, PaO2 of 70, C, PaCO2 of 40, or a D, a bicarb of 24. All right?
Is it B, PaO2 of 70?
Ooh, it's C. You were close, though. You were 1 letter away, which is good. So I'm going to talk through this. So the thing to remember with these asthmatics is beware the normal CO2. So early in an asthma flare, you're puffing and puffing, you're blowing off your CO2. That's where you get that respiratory alkalosis. But as patients get worse, we worry about that impending respiratory failure. Are they tiring out? So you'll see this pseudo-normalization of CO2. And on the boards, they may throw you this question, but they also may hit you with what's the next step. They love that, what's the most appropriate next step? And it's going to be something like non-invasive positive pressure ventilation or intubation. All right, let's do the wheel. Racking up some points here. All right, 500-point question. 55-year-old man is transferred to the ED from an outpatient surgery center operating room after he developed an increase in end-tidal CO2, tachycardia, tachypnea during elective rhinoplasty. He's already intubated on a propofol infusion. That's a disposition where I come from. And his temperature is 40 degrees Celsius. So, of course, they're going to throw us this. Which of the following treatments should be administered? A, bromocriptine, B, cyproheptadine, C, dantrolene, or D, succinylcholine? All right, Brandon, what you got?
What is C, dantrolene?
What is C, dantrolene? Perfect. And again, we will not ask you to dissect this, but I got the man for it. Sean Nort, break this down for us.
So this is clearly, and the clues are operating theater, operating room, inhaled anesthetics. So this is malignant hyperthermia. Remember, this is a genetic calcium ryanodine receptor problem. You can paralyze them and they will still be rigid. The actin and myosin are just bound together. Dantrolene is really the only thing. The hyperthermia actually is a later finding. It's really, you start seeing an increased PCO2, you see an increase in their heart rate, and then that rigidity. The other thing, so neuroleptic malignant syndrome, you usually won't see in the emergency department because that's an escalation of things like haloperidol from dopamine antagonism over days rather than minutes to hours. Bromocriptine is a dopamine agonist, and then cyproheptadine is an adjunct to serotonin syndrome. Clonus is the real thing that differentiates that, but this is malignant hyperthermia.
Yeah, that's a good thing on the boards, is that they usually have something consistent internally with one vignette. It's not as, real life is worse. So, he just gave us the classic presentations for each of those drugs, and that's why you'd use each of them, and that's how it's going to be. So that's one thing that's good about the boards.
Yeah, we talk about that in Invictus a lot, that the answer is generally in the question. It's just a matter of kind of slowing down and saying nothing is there without a purpose behind it. So I think that if you don't remember it, like I often don't remember it, you can get there a lot of the times. All right, who's got the hand on the wheel? Let's spin that boy. 100 points. This would be good. It's diarrhea related. A 45-year-old woman presents with severe abdominal pain, cramps, diarrhea, nausea, and vomiting 2 hours after a barbecue, unfortunately. She has no past medical history and is previously well. Which of the following is the most likely etiology of her symptoms? A, Bacillus cereus, B, Campylobacter jejuni, C, E. coli, or D, Staph aureus? Whoa, all right, whoa, we got a diarrhea fan, all right. What's it gonna be?
D.
D, Staph aureus. Perfect. We know our diarrhea well. So when we think about this, this is another great board question. I rarely on shift care at all why you have diarrhea. But on the boards, these are easy questions. So B. cereus is the preformed toxin, and generally that's reheated rice. I get nervous now every time I reheat rice just because of this. Campylobacter, you're gonna get dysentery, so kind of fever, bloody diarrhea. There's this association with the Guillain-Barré. So if you see that, that might be leading you towards that. E. coli's got a 1 to 2 day incubation period typically. Some of the subsets of that have this association with hemolytic uremic syndrome. Another, the boards love that. It sounds like a space station, but again, that's a different kind of timeline than you got. But this is classic Staph aureus. So preformed toxin. The mayonnaise is generally in the question stem, but I think just assume a good barbecue is going to have a mayonnaise-based dish. At least in Alabama, you have to have a mayonnaise-based dish to have a barbecue. And one of the other clues I've seen this question throw is there are going to be a lot of patients because everybody loves mayonnaise-based dishes. So if everybody shows up with diarrhea, these are all pointing you towards Staph aureus. All right, let's wheel it up. Racking up some points here, 300 points. All right, 39-year-old man and a 38-year-old woman are brought by ambulance to the ED for disorientation and agitation. On exam, they both have fever, sinus tach, dilated non-reactive pupils, dry skin, dry oral mucous membranes, and absent bowel sounds. This is the classic, I want to get weird, and we both want to get weird together, and that's how you end up in the emergency department. If you're going to get weird, have somebody there that's not getting weird, but these two got weird together. EMS says they shared a pot of herbal tea. I'm betting it wasn't exactly that, or sort of, and developed symptoms after 30 minutes. So what started as a vision quest ends up in your emergency department. What they get into, which of the following is the most likely causative agent? A, belladonna, B, cannabis, C, cation, that's probably not how you say it. If you're gonna take it, you should know how to say it. Don't take it. Or D, psilocybin. So what did these folks get into?
Belladonna.
Belladonna, okay. That's the right answer, perfect. So, Sean Nort, you are an expert in helping people understand.
And drinking tea?
Getting too
Belladonna
weird.
alcoholites?
You're always
Where
offering
am
me
I?
belladonna tea, yeah.
So this is pretty classic. If you even look, and what is interesting, right, they both get symptomatic pretty quick. So although they're febrile or hyperthermic, right, because they're not thermoregulating, it's very unlikely they both got meningitis in 2 hours or an hour or something like that. So Madrias blind as a bat, right? They're not thermoregulating, hot as a hare, all these things. Now they can be agitated and altered, but they're not violent. If you think violent, think of sympathomimetic. That's a fight or flight. That's the cathinone. Cathinones are bath salts, right? So clinically look like cocaine or methamphetamine. Psilocybin, it's very unusual for someone to wind up in the emergency department unless it was given to them unbeknowingly or they have a quote-unquote bad trip. But this is classic anticholinergic, or more specifically antimuscarinic syndrome. It's just benzodiazepines and maybe physostigmine. Physostigmine is an acetylcholinesterase inhibitor, and what that does is it kind of reverses it. There are some caveats. If someone has a known seizure disorder, or if they were on a cyclic antidepressant or something that could cause sodium channel blockade, we often will try to avoid it because it can not only cause seizures but can be associated with ventricular dysrhythmias. But generally, supportive care plus or minus physostigmine.
I feel like there are people that take bath salts and there are people that share tea, and there's very little Venn diagram overlap of I have a nice teapot and take bath salts. I'm sure you're out there, but that's a good clue that it's probably not the bath salts. Who's got their hand on that hot wheel? We're racking up some points. Let's see if we can stay. Oh no, we got a surprise joint commission visit. So you guys, unfortunately, your score goes to 0. Don't worry, there's more points. That it seems severe, but that's the way the game's played. And you guys can't buzz in. I'm sorry, these are just the rules. So you guys, you got an open basket here. 65, well, no, the wheel doesn't, oh, you didn't dispute, yeah, we need to know what you're playing for. 100 points, perfect. You guys, no points for you, sorry. 65-year-old male, history of COPD, presents with a 2-day increased cough and purulent sputum. He's placed on non-invasive positive pressure ventilation for respiratory distress. After 30 minutes, his VBG shows a pH of 7.28, PCO2 of 75, his baseline is 55. Which of the following is the primary physiologic benefit of the inspiratory positive airway pressure IPAP setting in this patient? I know that sounds unfair, but this is a free question. These guys aren't going to buzz in. So you don't have to buzz in. You guys can just answer. A, increasing the functional residual capacity. B, recruiting collapsed alveoli to improve oxygenation. C, assisting the diaphragm to increase tidal volume. And D, preventing upper airway collapse during sleep. No pressure. It's 100 points though. Guaranteed.
Inspiratory pressure is not going to change the oxygenation as much as the EPAP or tidal volume. Oh yeah. Oh, I thought we don't have to press.
Okay, you can press it. Press it if you want.
Press it if you want.
Yeah. So probably C.
Man, you guys are good. Free question. Yeah, so the basic things here is going to be EPAP versus IPAP. I apologize to the pulmonologist that I work with who are listening to this, but this is kind of the Delaney approach to not missing this question. EPAP is going to increase your functional residual capacity and improves oxygenation. You guys are mumbling and you nailed it. That's exactly it. IPAP is going to provide essentially pressure support, and it's going to reduce workup breathing. Your tidal volume will go up, and I think of that as that's what clears your CO2. So this does feel like minutia, but that's what the boards do. We all know how to treat this patient. These do feel like unfair curveball questions, but classic board review. All right, we're gonna spin the wheel, get you guys back above 0. Oh no. You guys, the Pixis is on fire, so now you go to 0. Who made this game up? This is crazy. Spin it again. 100 points, so we got 0 to 0, it's getting close. Halfway through, we're neck and neck at 0. A 5-year-old child presents to the ED with abdominal and joint pain. His vitals are unremarkable. Discharge. Physical exam is notable for palpable purpuric rash on the buttocks and lower extremities. Not a discharge. All right. Which of the following diagnostic tests is most likely to support the diagnosis? The classic boards, just tell me the diagnosis, but no, we've got to know the diagnosis, then what is going to most likely support it? Is it A, a CBC, B, a CMP, C, a CRP, or D, a urinalysis? Ooh, quick on it.
We'll go with D.
D, urinalysis. That's a correct answer. You're back on the board. Congratulations. So this is a great question. So
go back to the question. I think it's helpful to look at to all the answers and kind of that's an easier way to sort through it. This is actually this is a subtle thing. It sounds like HSP, right? I mean, it sounds like IgA vasculitis, because whenever they show you the backside of a kid with, a rash on it, that's what it's going to be on the boards, right? So that's, but there's a subtlety there. Like, is a CBC necessarily wrong on a kid who's got a petechial rash? Well, what if the platelets are really low? That sounds like a reasonable answer. Like that's a reasonable thing. But that's a blood stick, right? Complete metabolic panel. What's the most common complication of HSP? It's renal, right? And so you want to screen for renal. So maybe you're thinking, okay, well, they can check the electrolytes of creatinine. Sounds reasonable, right? Those sound reasonable. C-reactive protein is wrong because, it's just totally nonspecific. And then you get to urinalysis and you're like, wow, a way to do, if there's no blood stick, urine is the screening test for renal problems, which is the number one issue in HSP. And that's probably a better screening test than anything else there. And that's sort of how I get to the right answer.
Yeah, that's a great breakdown. And it also kind of the way you talk about it, that these may be things we do in real life, but this is the boards. This is not real life. So the pause, even if we had ordered most of these at the same time.
And the perfect example in this question actually is that we don't do a complete blood count to check for low platelets because they told us in the question that it was palpable purpura. And you're all like, sometimes clinically it's hard to tell, is it palpable, is not? And you would maybe order a CBC in the kid. But when they tell you on the board question, it's palpable purpura, they're telling you it's not CBC, it's not platelets. You're barking up the wrong tree. So, it's easier than real life, is what I'm saying.
At times, it's easier or a whole lot harder.
Yeah, it can be.
All right, let's hit that wheel again. 100-point question. Close race still. A 58-year-old man presents to the ED with acute onset of lip swelling and progressive throat tightness. There's no urticaria, vomiting, or wheezing. His blood pressure is normal. He got 2 doses of IMEPI, no change, and he actually has to get intubated for airway protection. Now the family shows up and surprisingly is quasi-helpful and say, yeah, I don't know, he's had weird things like this in the past, but he's not allergic to any things, and he's not on any medications. So what medication should be given to this patient? Is it A, C1 inhibitor concentrate, B, fresh frozen plasma, C, methylprednisolone, or D, tranexamic acid? Brenner. A. C1 inhibitor concentrate, very well done. So what we're talking about here, again, this is a great example of the boards. They will give you a clue, and the fact that the family is there, I think, takes a difficult question and makes it solvable if we slow down and read the question. So C1 esterase inhibitor deficiency, the treatment is A, C1 inhibitor concentrate. The issue is you build up too much bradykinin, that's where the swelling comes from. So you basically have to just give them the inhibitor that they're deficient of. The trick here is that fresh frozen plasma is a second-line treatment, but it's going to be the most appropriate thing. Not what you give in your shop, but in a perfect world of the boards, what would you give? Methylprednisolone, again, I don't think it's wrong clinically to give this patient steroids, but they give us enough in the question to make us feel comfortable that this is not a disease that steroids will fix. And tranexamic acid, we do try it for almost every indicated chief complaint, but it does seem to have, like with a lot of things, minimal impact on this issue. All right, we got time for a couple more questions. Let's hit that wheel. Now this could be the game changer. 500 points. I would say both teams could use this. So 21-year-old man presents to the ED with headache, fever, and neck stiffness. A lumbar puncture is performed. Which of the following CSF results is most consistent with the diagnosis of bacterial meningitis? A, CSF white blood cells of 5 and a protein of 275. Elevated CSF to serum glucose ratio, C, an opening pressure of 12 centimeters of water, or D, predominance of polys. We got a real CSF fan here. I like it. All right.
I think it's D, right?
D, predominance of PMNs. So that very well done. All right, expert panel, walk us through. Let's go back to the question for you.
Yeah, go back to it. Okay, so CSF white cells of 5 were really, really, really low. Is not classic for bacterial meningitis, although the protein's really high, and that makes you think it could be. If it was really early, A could be the right answer, so it's possible. But then they say B, there's too much glucose in the CSF. It's the opposite, so that's for sure not true. Opening pressure normal, that's not the right answer, right? Because they're going to be high. So then it comes down to A, and then D, predominance of polymorphs. Well, that's kind of classic, right? I just wanted to point out, though, that if they didn't have that as D, A could potentially be the right answer. That and clinically, that's what you should think. If someone comes in, they look sick, you should think it's bacterial meningitis, but it's not as good an answer as D. So that's how I would interpret that one.
Well, Stuart, I think that's a really good example of not overthinking the question, right? You've got two that might work, but you're going with the classic finding, because again, to sit down and write a test, you do have to throw some classic things your way. So, all right, let's see what we got next. Somebody hit that wheel. 100 points. A 58-year-old female is intubated in the ED for severe pneumonia with ARDS. She started on volume control ventilation with a tidal volume of 6 cc's per kg. Shortly after intubation, the ventilator's high pressure alarm sound, assuming you can hear it, and you note the peak inspiratory pressure is 45 and the plateau pressure is 25. Which of the following is the most appropriate next step to address the elevated pressure? Is it A, decrease the PEEP to reduce the risk of barotrauma? Is it B, suction the endotracheal tube and check for, quote, patient biting? C, increase the tidal volume to 8 cc's per kg to improve ventilation? Or D, obtain CT imaging to evaluate for pulmonary embolism? That's always a reasonable answer, is get a CAT scan, but I don't think that's where it's leading us. So, all right.
Suction the ET tube and check for biting.
Very good, B. So really, the way that I would think through this question would be if they have a high peak inspiratory pressure and a normal peak plateau pressure, that's airway resistance. That's the situation they're giving us here, and that's going to be bronchospasm, potentially biting or then secretion. So the suctioning works well there. Check for biting. If you've got high PIP and high plateau pressures, you're going to think lung compliance issues like pneumothorax and ARDS. So again, troubleshooting vents and this kind of question I would expect to see on the boards. Very well done. So let's do a couple more here. Let's spin that wheel. 300 points. A 19-year-old male is brought to the ED after an intentional ingestion of an unknown substance 3 hours ago. He's trying to have a good time. He's now complaining of ringing in his ears and nausea. His vitals are a respiratory rate of 32, heart rate of 105, BP is 120/75. His ABG shows a pH of 7.32. The PCO2 is 18 and the bicarb is 10. Which of the following represents the most appropriate therapeutic goal for this patient? Is it A, immediate intubation hyperventilation to get the PaCO2 of 15? B, administration of intravenous sodium bicarb to achieve a urinary pH of 7.5 to 8? C, initiation of a dopamine infusion to maintain renal perfusion? Or D, administration of IV fluids and furosemide? What is it?
B.
B, alkalinize the urine. Very well done. So, salicylate toxicity, and Sean, we'll get your kind of color commentary here. Mixed acid base, you get that primary respiratory alkalosis, primary metabolic acidosis, and talk to me about ion trapping.
So ion trapping is exactly what he's saying by giving bicarb. So what you want to do is make it positively charged. Don't worry anything more than that. What that means is we keep it either the serum pH to 745 to 755 or the urine pH to about 8. Because if it's positively charged, it can't cross membranes, meaning into the brain, cause cerebral edema, seizures, or into the capillary bed, cause a non-cardiogenic pulmonary edema. This is a temporizing thing, though. It's a great board question, but the reality is hemodialysis, if it's indicated, is the real treatment. But when you look at all these things, and be comfortable with calculating blood gas analyses, because if you see a mixed acid base as you do on this, and it's in particularly a younger person with presumably an acute ingestion, the list is pretty short. The list is much longer if it was an anion gap metabolic acidosis, but in the setting of a mixed picture of the respiratory alkalosis with a metabolic acidosis, it almost can't be anything else than salicylate poisoning in this scenario.
I love the question stems where it's like, this guy took something, what did he take? I don't know. You have enough information, he needs to go to the hospital. So it's a classic, the boards love salicylate toxicity. And also, I've seen questions where they'll throw you that elderly patient who has this, where it's not the obvious overdose attempt or kind of therapeutic misadventure, and so it's kind of the acute on chronic. So that's, again, I don't alkalinize urine often, and that means the boards like to test us every time we sit down to take them. All right, who's gonna hit the wheel for us? A couple more times to get some points on the board. 100-point question. A 34-year-old female arrives at a mountain resort at an elevation of 11,480 feet. That's a very high mountain resort to sleep at, but the snow is going to be good. That's why.
Cusco.
You're up there.
Cusco.
I would advise, don't do that. Don't go from sea level to that. But here we are. Within 12 hours, she gets a headache, nausea, and significant fatigue. Yep. She's awake, alert, unhappy, has a normal neurologic exam. So whiwhich of the following is the first line pharmacologic treatment for this patient's condition? Is it A, dexamethasone, B, acetazolamide, C, nifedipine, or D, sildenafil? B, acetazolamide. All right, so what we're talking about here, in a lot of these kind of environmental questions always pop up on the boards because if you don't work at altitude or you don't work where it's hot or cold, you don't see these patients a lot. So I think this is very fertile ground. And I would say before you sit down for the boards, review these kind of things. But what they want you to do here is pick up on what's wrong with her, skip past that and figure out what do you do for that. So acetazolamide, she's got acute mountain sickness, right? She has the classic story. I went way too high in elevation. No one can handle that well other than Sherpas on Mount Everest. But so the treatment there, in her presentation is she's just unhappy. She has a headache. She feels really crummy. Acetazolamide is going to be the treatment there. So what that will do is it induces a bicarb diuresis and you get a metabolic acidosis, so you breathe faster. So that's kind of how you fix it, is just take that. All your carbonated beverages and beers will taste horrible, but you will feel better, which is good. If the patient was sicker or had different symptoms, you think about is this high altitude cerebral edema or HACE. Dexamethasone would be the preferred kind of treatment for that. And they said pharmacologic because descending is often the right answer. If you say go to lower altitude, that's going to be the answer. But if they say pharmacologic, they're going to point you towards dexamethasone. Now this is second line for acute mountain sickness. So this is a little bit of a trick in there. But say she had HAPE, if she had pulmonary symptoms, that's where these other two options would be the choice. So even if you're not totally sold on, well, I don't know what category she falls in, I think you can reason through these questions and get to the right answer. All right, let's spin the wheel. I think we got time for one more question. This is good. This is helpful for both teams. 500 points. Final question. A 70-year-old man is sent to the ED after an outpatient abdominal CT revealed a 4-centimeter infrarenal abdominal aortic aneurysm. He has no symptoms and it's otherwise well. What is the appropriate management of this patient? A, admit for inpatient evaluation. B, discharge home with surgical follow-up. C, immediate vascular surgery consult for surgical repair. Or D, IV esmolol and nicardipine to maintain systolic blood pressure less than 120 millimeters mercury. What do you got?
B.
B, discharge home with surgical follow-up. That's exactly right. And so this is a theme that the boards love, which is this less is more approach. And so you'll get these question stems, and I don't remember what size of AAA should make me do something, but if you see an answer that jumps out that's like do nothing but get outpatient follow-up, there's a reason that's on there. And so just the pearl is going to be anything less than 5 centimeters in an asymptomatic patient with a AAA can go for outpatient follow-up, but that less is more. You'll see those antibiotic questions with kids with otitis media, things like that. Don't be afraid to choose the do nothing but kind of tincture of time.
That's another thing that makes the boards better than real life, because in real life you always have to stress, oh, maybe I'm wrong, and the boards, they just say, no, it's not that. You know, she's not altered. It's not high altitude cerebral edema. Don't worry about it. And you don't have to worry about it. You can be that clinician that you've always wanted to be, you know.
For one day.
For one exam.
For a couple hours, you pay a lot to go sit through.
And then it's back to shift. Yeah.
All right, so thank you to both of our teams for playing. All right, we've got the score coming from the back. Wow, there were some peaks and valleys here, but it looks like Team Encore is the winner with 1,300 points. So very well done.
Yeah.
This team won. You're all going to get prizes. We're going to go to Mies in just a second, but if you're playing at home, here are the trivia questions. And again, go to YouTube, go to the chat, and answer, and then you can win either Invictus Reviews or Invictus Encore subscription. These are big prizes, folks. So the first trivia question is, where in the EMRAP universe do you find the study guides? That's the question. Just tell us where. How would you find them? Britt put a bunch of stars up and showed you a bunch of different ways, but where do those live? And the second one is a little bit more, you got to know your geography and airports a little bit, but if you're going to take the new oral certifying exam and you want to find the closest airport to the test location, what is the 3-letter abbreviation or the 3-letter code for that airport? This is actually the easier question if you ask me. But so those are 2 questions. Where do you find the study guides? And then what's the call sign for the airport? Go into the chat and we will announce the winners in a little while. But right now, before we get to Mies, here's a little bit of a palate cleanser from the kind of brilliant minds that put all of this together.
Too oaky. Awful. Lame. What are you looking at? Too piney. Don't like it. Boring. I can't see. Too woody. Bollocks. Boring. I said I can't see. Not woody enough. Absolutely awful. Boo! Ow.
All right, one of the biggest stressors this year has been what to expect with this new oral board exam, also known as the certifying exam. This isn't just stressful for residents, it's also stressful for program directors because quite frankly, no one has seen the structure of this. So we sent out our 3 experts, Dr. Chris Riley, Dr. Jesse Werner, and Dr. Mac Brown to investigate. They've given you a layout here of all the different clinical scenarios that they are going to test you on, various case scenarios, as well as communication cases, and then also procedure interactions and ultrasound interactions. In the clinical decision-making case, you're going to be given clinical scenario stems and then have to be able to walk through and justify some of your actions. Prioritization is much like a triage case or a mass casualty case where they're going to give you multiple patients at one time and you have to be able to determine which tests you want at what point and be able to prioritize your workup. Managing conflict is an interesting one. This is where you may be in an altercation verbally with one of your consultants or even maybe with a difficult patient. You're going to be tested on your social skills and your ability to communicate. Difficult conversation, things like delivering news of HIV or perhaps a loved one that has died in the ED, having a patient that you have to be able to walk through and emotionally care for. They're sort of testing not just your IQ here, but your EQ as well. Then there's lots of patient-centered communication, being able to empathize with patients and understand their social needs as well as their psychosocial needs and physical needs. And then lots of reassessment and troubleshooting. So this will be something like a patient comes in for abdominal pain, but ends up developing chest pain, and perhaps you need to reassess the patient for a new EKG, etc. They are going to test you on ultrasound. Now, ABEM expects you to have the basic ultrasound skills that you need in order to be able to diagnose. They may give you images, or they may actually have an ultrasound machine in the patient room, and you have to physically do the exam. So you need to be familiar with all of your basic ultrasound skills. Same goes for procedures. They're going to walk you through various procedures, possibly directly on a patient or on a model itself in the room. So there are lots and lots of ways you can do this. You definitely want to be preparing and trying out all the various clinical scenarios through practice cases. And ABEM did give EMRAP a quick sneak peek into the new testing site. Chris Riley went down to Raleigh, North Carolina himself. We wanted to give you a sneak peek into what you're actually going to see on test day. So here you go.
Here's what to expect when taking the new ABEM certifying exam down in Raleigh, North Carolina at the AIM Testing Center. The testing center is right here in the middle of these 3 hotels. You're about 2 blocks from the testing center and it's super easy to get there. ABEM recommends you stay at the Hyatt House, Raleigh North Hills, where there is a room block, and this is where the exam registration will actually be held. Once registered at the hotel, a proctor will escort you to the AIM Center. You're going to go with your group right to the 15th floor. You'll either make a right or a left, depending on which side you're actually looking at. Examinees will be provided lockers to place prohibited items like phones, watches. Your proctor will then direct you to the waiting area just outside of the testing rooms. You will then look for the room or chair number that was assigned to you when you checked in. You'll see various setups for your exam based on the type of scenario you are taking at that time. Patient encounter rooms are set up with hand sanitizer stations, a desk with 2 chairs, and a gurney. This testing center is going to set up everything to make it the least stressful day possible for all examinees. They want to make everyone's test day as easy as possible. They want no stress for anyone, and proctors will be on site to help guide you and make the process as smooth as possible. I hope this little video helps. You can also find more information on the ABEM site, and I really do think this is going to be making things a lot easier and a lot better for the overall practice of emergency medicine.
Delaney, I think we have 2 trivia winners. So tell me who's going to win Encore.
So there's a little trick. We don't know your real name. We know your YouTube account name. Thank you for having ones that are PG-ish related that we could say. So when we say your account name, write us an email at events@emrap.org and we'll hook you up. So the trivia winner is Senga1212, Senga 1212, and that's for Invictus Reviews.
That's for Invictus Encore.
You get Encore.
Yep, and then the second winner is?
I'm going to say it and spell it. Mummin Mushtag 38. I like that. We'll give you some extra swag if you tell us what that means. MUMIN, Mushtag, standard spelling of Mushtag 38. So again, events@emrap.org.
Please email us. All right, special thanks again to our USC and UCLA residents who joined us tonight. It was so great having you guys in studio. We plan to do more of these. We hope it was helpful, so we can't wait to have more live events in the future. Until then, keep going, keep studying, and stay connected.